Welcome to this genetic and molecular testing talk. It's a good thing I'm not the one giving the talk because I can't even say the words. So fortunately for us, we have Dr. Aime Franco with us. Dr. Franco is an assistant professor and investigator with the Center for Childhood Cancer Research at the Children's Hospital of Philadelphia in Philadelphia, Pennsylvania. Dr. Franco directs the newly established Pediatric Thyroid Cancer Translational Research Laboratory. Her research interests include the molecular biology and genetics of thyroid cancer and improving quality of life and survivorship outcomes for thyroid cancer. She's a 2012 recipient of a ThyCa thyroid cancer research grant. So thank you, Dr. Franco, for being here.
Thank you so much. The other thing that I will add is I am also a thyroid cancer survivor. So I was diagnosed when I was 22 with follicular thyroid cancer. I wish there had been genetic and molecular tests around. My diagnosis predated the ability to really get genetic and molecular testing done. And also, I think, I would be remiss to not mention that genetic and molecular testing isn't available to all of us and to everybody. And so I hope through the course of the next little while, we'll try to demystify a little bit about what genetic and molecular testing can tell us, what it can't tell us, what it's actually measuring and doing. And I really welcome interruptions. I'd really prefer this to be a dialogue than me sitting here talking for the whole time. So please feel free to interrupt me as we go through all of this. So what are molecular tests? So I'm sure many of you have heard, or maybe you haven't, about some of the molecular tests that are offered a lot of times to thyroid cancer or potential thyroid cancer patients at the stage of FNA. So we're going to kind of talk about it at a couple different levels of where we could intervene with genetic and molecular testing and what that does at those kind of different time points and what information we can get out of it. But the major ones that we traditionally talk about are Afirma, ThyroSeq, and ThyGen-Next or Thyromere. Each of these are actually a little different depending on whether they're looking for mutations and looking at your DNA versus your RNA versus your actual microRNA, which, alphabet soup. And we'll talk a little bit about that. But really, I wanted to really emphasize the difference between what we talk with molecular tests, which would be these Afirma, ThyroSeq, ThyroGen-Next. This is when FNAs would be sent out and we would talk about getting molecular testing versus genetic testing, which is another component of this. But with genetic testing, we're looking for germline mutations. That's when you can get it from a cheek swab, sometimes from a blood test, sometimes from saliva. This is 23andMe. When you send out your DNA, that's genetic testing. So they are very different. And the reason they're so different is where they're looking for different changes in your DNA. So DNA is our blueprint, right? We all have DNA. It's in every single cell of our body. It dictates how things are done. It's our overall blueprint, master blueprint. But when we talk about doing genetic testing, primarily we're looking for germline mutations. This is what is located, and that's your DNA that's in every single cell of your body. This is not looking for a specific mutation that's your tumor. This is looking for risk factors. This is looking for mutations in the DNA. And that means if it's in the germline, that every single cell in your body has it. Your thyroid has it, but so does every other cell. Whereas when we talk about molecular testing and we're doing this off of our FNA or looking at it for diagnostics and thinking about it with thyroid cancer, we're talking about looking at somatic mutations. And those are the mutations, that's where your DNA has something that's gone wrong, but that's specifically only in the thyroid cell. Those mutations are only in the thyroid, they're not everywhere else. So it's really important to kind of think about this and to know the difference between the two, because this information becomes really important as far as how you interpret it and understanding whether it's everywhere or if it's really just in your thyroid. So I'm going to first talk a little bit about germline testing, and then we're going to move on and we can talk more about some of the molecular tests. But again, anyone who has any questions or concerns, please stop me along the way. So germline testing is usually done with a genetic counselor. It's become actually quite easy to do genetic testing for, because a lot of us can spit in a tube and send it out through CVS and get results back. might not know what to do with those results, especially when things come back and say they may predispose you to getting something or increase your risk. How do we even evaluate that? How do we take that information and do anything with it? It can be extremely overwhelming. So I do think that germline testing, especially when we're thinking about it in the context of cancer, when we're thinking about that as being a risk for cancer, it really should be done with a genetic counselor for someone to help put it into perspective. We can't even talk about all of the different perspectives in the course of an hour today, but just because you have a mutation does not mean that you're going to get cancer or you're going to get a disease or have a problem. Like I said, DNA is your blueprints. So when we have a mutation, that's a typo. And if your blueprint has a typo, maybe they'll build the building wrong, but maybe they won't, right? It doesn't mean that the building's going to collapse. It doesn't mean that there's going to be something wrong. It means that there's a chance something can go wrong. So I think that's something to really think about with these germline tests. But in thyroid, we often hear, and you may hear buzzwords like Dicer1. This is a germline mutation that can predispose to nodules as well as a lot of other cancers. P10 mutations, Cowden's disease. This can also lead to predisposition. But we also talk about germline a lot of times with MEN2A, MEN2B, medullary. A lot of medullary cancers can actually be tracked through germline mutations, and that can increase our risk for developing medullary cancers. And I just put it up there, although it's not associated with thyroid cancers, but we hear so much about it in the news, BRCA mutations, and that's something that comes up so often when we talk about germline mutations. The other thing that's become really in vogue recently, well, I wouldn't even say just recently, but not just looking for mutations in the blueprints, but you might hear somebody talking about SNPs and small nucleotide polymorphisms. These are just little pieces of that blueprint that has a different insertion in there. You know, it was a typo that maybe you got 2 A's writing the word out, or somebody dropped the E on the end and you're just not quite sure. We don't know what all of these things mean, but this is really where we're moving forward in a lot of our genetic testing now. This is much more to research level, but trying to understand how all of these SNPs that everybody has, but these little typos and these little differences that are unique to each of us, and how this may be not always driving cancer, but might be a marker of whether we're at bigger or at greater risk or lesser risk. So these aren't going to be tests that are going to be diagnostic to tell you yes or no, but they could be something along the lines, probably not for us, but hopefully for our children and maybe our grandchildren, that they'll be able to have these types of tests and know, you know what, you really are at risk for thyroid cancer, but you're not at risk for breast cancer, or you're risk for breast cancer, but you're not at risk for thyroid cancer. And hopefully some of those things can help us down the road with some of our screening so that we can try to predict what's going to happen before it actually does. Sure.
So we have an online question from someone who's had prior Hürtel cell neoplasm FNA, followed by benign with negative ThyroSeq3. Last FNA 4 years ago. Would ThyroSeq3 give me any more info to clarify on Hürtel cell neoplasm? And is it better than a firm elite in this particular scenario? Given that I received 2 different results from the same nodule, with ThyroSeq findings also different dependent what types of cells were obtained from the same nodules where the needle went?
All right, so that's a loaded question with a lot of information, and I'm going to say that I'm not an MD, so I'm not going to give some clinical information on this, but I will say each of these tests is kind of what I've talked about, is it's evolving constantly. So what we knew with some of these earlier versions, we now know different mutations that are present. We know things that are different about how they increase the risk. And exactly what this questioner asked about is when they went and did an FNA, it all depends on where the FNA was sampled, whether they actually got thyroid cells or whether we got other cells. And as we talked about with the germline testing, what we're talking about here, this is mutations, and these are changes that would be seen in every single cell, no matter what we got. When we start to talk about molecular tests, the Afirma, the ThyroSeqs, those doing them off of an FNA, we're looking for those changes that are specific only to the thyroid cells. But during an FNA, you don't get just thyroid cells. When you go in for an FNA biopsy, you get blood cells, you might get fibroblasts, you're going to get some of your blood vessels that are in there. So there's a lot of other cell types that are there that aren't thyroid cells that wouldn't have the mutation. So that creates the problem. So this is, some of the selection bias that we get just when we do these types of biopsies. So it's hard to say, and I couldn't give a clinical diagnosis for that, but I think each of these tests is continuing to evolve, and we actually add more mutations with the Thyroid test that actually talks about microRNAs. We won't go into that unless people want to talk about it, but it's other factors and other types of changes within these codes in your body that may help us diagnose whether that it's truly a cancer or whether it's benign. So we've started to hit on this, but DNA, RNA, and more. So like I said, the DNA really is our blueprint. And when we look at germline testing, we're looking at the DNA and we're trying to figure out, is there something wrong with the template that tells all of our cells what to do? Doesn't mean that they're always going to go wrong, but there's the possibility with some of those mutations or some of those changes that something could go wrong down the road. Molecular tests look at DNA, but now instead of looking at the blueprint in all of your cells, we're starting to look at the DNA and the DNA that's unique to each of your tumor cells. RNA is what happens. So your DNA makes RNA. So if DNA is the blueprint, RNA is kind of the scheme and the walls as they start to go up, right? We use the blueprint to figure out how to build it, but the RNA is really the materials that actually starts getting used to build everything and give us that signal and tell us what to do. So the molecular tests now, we start to move beyond just looking at the DNA, but we start to also look at the RNA and looking at how things are being built. And this starts to give us some clues about whether cells may be cancer or they're not cancer, and then what we can do with that information. So as I had said, blueprints, that the DNA, it's really kind of the blueprints of our life. And when we think about the germline, we're building the foundation, right? If the foundation is wrong and there's something wrong there, then you're a little concerned that maybe the house might fall down at some point, but it doesn't guarantee it's going to. And I think that's something that's really important to understand with all of these tests. And we're going to talk about what they don't tell you is that nothing is a crystal ball. Just because we find something wrong does not mean that it's going to be catastrophic. Particularly when we look at some of these germline mutations, a lot of times they just increase your risk, but it doesn't mean something terrible is going to happen. And I put this up here. This is just some information that came out of Ohio State, but it's just looking at, and I don't want you to look at and remember all of the different mutations and conditions and things like that. But I want you to look at this, the lifetime risk, right? When we find these mutations, we're not talking about a guarantee that you're going to have cancer. P10 mutations, it's a 3 to 10% risk over the course of your lifetime. It means we just have to look more carefully, that we know that you have that risk and we're going to watch you a lot more carefully. But it doesn't mean that it's a death sentence by any means. And it doesn't guarantee that any of these things are going to result in thyroid cancer or any other cancer for that matter. So I think this is why I emphasize, I think it's so important when we think about these tests and when we start to use them, is to have a really good dialogue with your physician and with a genetic counselor, because there is so much information that comes back and it sounds horrific and it sounds really overwhelming. And if you don't get into some of those details and really understand, it's a risk. It's a 3% risk over the course of your lifetime. This is not a 90% risk. And trying to put it into context. And I can say it, I went through this, right? I went through the FNAs, and like I said, that was pre-molecular test, but I know the anxiety that we go through and the answers that we want. And unfortunately, none of these things actually give us those surefire black and white answers sometimes. So that was talking about germline. And as we go into thinking about the molecular tests, now we're starting to think about what are those changes that are happening in the thyroid itself. And there's a couple different ways in which we use these tests. The first instance now is starting to use it at the FNA level, right? When we go in with an FNA and we see that those cells have indeterminate cytology, my favorite thing, unknown significance, right? We start to use some of these molecular tests to see, are there changes that we're detecting that may be predictive and give us a higher likelihood of this really being cancer, or is it going to remain benign and just be a nodule there that's going to sit. And that's when we go into the molecular tests, and we see that we use these molecular tests a lot of time to try to predict whether it's a high chance of having cancer, whether we want to go with a total thyroidectomy. Is there an intermediate chance of cancer? Maybe it's a lobectomy, and maybe it's a low probability. But unfortunately, there's quite a few of these mutations that we find that really don't give us a whole lot of information. And it's really frustrating. I can tell you it's frustrating to us on the research, it's frustrating to the clinicians, and it's frustrating as a patient. One of these is RAS mutations. I don't know how many have heard of RAS mutations, but we see this, and we were actually talking about this outside before we came in here. RAS mutations are seen in everything, benign nodules, all the way to anaplastic thyroid cancers. So it really, unfortunately, doesn't give us a real good prediction when we find it at the FNA level, if those cells also aren't telling us that it really looks like a cancer. So there's pros and cons to each of these tests, and they don't tell us everything. The other thing, and what comes into play here, is the different molecular tests. So I mentioned them. There's Afirma, there's ThyroSeq, there's ThyroGenX. They all look for slightly different things, but most of them are actually looking at panels. And when I say that, we have a set of mutations that we know are usually associated with thyroid cancer, so we look for those. That's the easiest thing. Instead of doing a complete fishing expedition looking for anything that might be out there and any changes, because we may not know what to do with that information. The problem with this is it doesn't tell us everything. And we're all an N of one. Each of us is unique, and each of us sometimes has those very special mutations that haven't been seen before. The other thing that we know is that the mutations are different between adults and pediatric patients. So I have transitioned and do a lot of work right now in the pediatric space. That's where we're doing a lot of our research. But the mutations that we see in pediatric patients are different, or they're found in different prevalence than what we see in adults. For example, in adults, we see a lot of BRAF mutations. People have probably heard of BRAF V600E. We see RAS mutations. We sometimes see fusions. We talk about RET or NTRK fusions. These are extremely common in children. However, because we don't see them in adults, they're actually not on any of these panels, or they test for some of these RET fusions, but most of these NTRK fusions, at least in some of the older panels, weren't even there. So because we look at this and try to narrow it down and look at those things that we hope will be most predictive and give us the most information, it doesn't cover everything, and it means it doesn't always work for every patient. So they're not going to tell us everything. The other thing too is that we're looking for this just in your tumor cells. And we already hit upon it that when we go in with an FNA, we hope we get the tumor, and you hope that you've got a really good radiologist that's doing an ultrasound guided FNA, but maybe they aren't, and maybe they missed the tumor and they only get normal cells that are beside it, or maybe they only hit a bunch of blood cells and they actually didn't get thyroid cells. So it's not perfect, because we don't always know exactly what we're taking out of that FNA. And when we send it out and we start to look for these mutations, we may not find it just because we didn't get that cell. We didn't get lucky enough to hit the tumor. And I put this up because, I think the main reason, or the first stage at which we use a lot of these molecular tests, is in the diagnostic stage, right? We go for an FNA, there aren't enough cells, or the cells aren't telling us whether this is truly a cancer or it's not. So we then, hopefully, most people will have access and have a physician that will be able to send for molecular tests. And when we send for molecular tests, again, usually we're just looking at a panel. We're looking for a lot of those things that we know are most often associated with thyroid cancer. And then again, this is going to start to give us a risk factor. Again, it's not the crystal ball. It's giving us a prediction of what we think it is. The other thing that's really difficult with this is that most of these mutations that we know predict for papillary thyroid cancers, BRAF, they have a high likelihood of malignancy and for truly being cancer. A lot of these other mutations that are associated with follicular thyroid cancers, they can be there when it's not a cancer. And a follicular thyroid cancer can only be diagnosed after it's taken out. We can't look at the cells of an FTC and know it's cancer. We have to take that tumor out and see that it's actually invaded into either the blood vessels outside of the thyroid capsule, into the lymphatics. So unfortunately, even for FTCs, we have predictive value and we have some of these markers that may be more likely to be associated with the tumor. But for most of the patients like myself with FTCs, it really isn't until we go in for the surgery that we're going to find out what's going on. I don't know if there's anyone that has any questions at this point or if we had anything online. Yeah, please.
You said that there were more children or pediatric patients that had Rett as opposed to adults. Why is that?
It's a great question. We don't know. Rett, no. So we don't know. This is what's really interesting. This is one of the reasons why I moved my lab to the Children's Hospital of Philadelphia, is to try to understand this. We really don't understand why children are more likely to have fusions. So there's also a difference between having Rett mutations. So we see Rett point mutations in thyroid cancer, and then we also see Rett fusions where, yep. So, but for some reason, I mean, we see Rett fusions, we see NTRK fusions in adult, but they're much more common in pediatrics. 20 to 30% of the pediatric patients we see actually have fusions, where in adults, it's the tens that percentage-wise of all of the tumors when we look at them as a whole. No, well, so we think that pediatric tumors are a little different than adult tumors. And we don't understand exactly why. We don't know what is different about the biology. But for some reason, the kids just develop mutations in different prevalence. And we still catch them and we remove them. It's just, it seems like there's a different insult that's causing that damage perhaps in children for them to develop tumor or to develop thyroid cancer than that insult that is happening in the adult space that we don't understand. Yep. So my understanding is that Hürthle cell neoplasm corresponds with hamartomas and other body parts in P10. Is there any other gene associated with Hürthle cell and hamartomas? So P10 is most often associated with the hamartomas. So the Hürthle cells, actually, we don't understand a lot about what mutations are associated with Hürthle. We used to think they were much more like follicular thyroid cancers, and at one point they were classified as a subtype of follicular thyroid cancers, meaning most often we found they were associated with RAS mutations. That doesn't seem to be the case now, and we really just don't understand all of the genetic changes and the mutations that occur in Hürthle cell to have a signature or a genetic mutation that's specifically associated with it. We're working on it, but right now we're not there. So with that, we've kind of started to hit on it, but what drives thyroid cancer? So we know that thyroid cancers, for the most part, all of these mutations activate almost the exact same pathway. It's called the MAP kinase pathway. Doesn't matter. We're not going to go into all the biochemistry and all of the fun science that I like to do, but almost every single thyroid cancer that we have, whether it's a papillary thyroid cancer, a follicular thyroid cancer, or it's progressed and it ends up being an anaplastic, poorly differentiated, and even medullaries, which aren't from the thyroid cells, but from the C cells in a cell within the thyroid gland, they all activate this pathway that's called MAP kinase. But what's really interesting is that the way they activate it are different between whether they start as a PTC or whether they start as an FTC. We don't understand why that biology changes. And we don't understand why it matters, but it happens all of the time. And as you can see over here, it already came up P10. So P10 is associated with the hamartomas, and it's often associated with the Hürthle cells. it comes in from that, like you can see this, it comes in from a different direction and activates the pathway. But it's almost always associated, at least at the beginning, with follicular thyroid cancers, whereas BRAF mutations, these RET PTC rearrangements, are often associated with papillary thyroid cancers. Again, it's all activating this exact same pathway. Biologically, this activation is, we think, is all the same at the end of the day, but depending on where in that pathway you activate it, you end up with a different subtype of cancer. Yep.
Your image on the slide makes me think that ATC always arises from FTC or PTC. Is that true?
That's the $1 million question. And we were actually just talking about that outside. We've thought, and the dogma has been, that we think it arises from a PTC or an FTC, and it advances and moves through a poorly differentiated state and then gets to anaplastic. I will say my own personal opinion is that there's also a subset of anaplastics that just develop as anaplastics. Perhaps they went through a stage of follicular and papillary for 2 days before they got to anaplastic, but I think it's so rapid that it's not that it was a well-differentiated tumor that we missed all of the time. We're still trying to figure this out. We know in a lot of anaplastics that there's areas that we can find that still look like a PTC or look like an FTC, which makes us think that there is a progression. But it's not, thyroid cancer doesn't follow the same rules that some of the other cancers like colon cancer follows, where you find a polyp and then it gets one mutation and another mutation and another, and it kind of goes down this pathway from polyp all the way to the most severe forms of colon cancer, and we can usually predict it. Thyroid cancer doesn't follow the same kind of rules, and we don't know why. But it's a great question, and we used to spend a lot of time, and you'll see it, I'm sure, in some of the other talks. We didn't talk about the mutations as much in anaplastic because we knew how significant and how severe anaplastic was, and we knew it. We had to treat it right away. We didn't pay as much attention to those mutations. Yep. Okay. But the next slide I'm going to talk about is what we do. I mean, we talked a lot about the molecular and how we're using this to diagnose. I want to talk about it in a minute about what we're going to do with those mutations after we have a cancer. So one is, can you talk about NTRK gene fusion treatment? What are the second and third generation treatments you might highlight? And then, is anaplastic diagnosed from FNA? So we're going to talk about NTRK in just a second because we're going to talk about how we use these mutations. Anaplastic, is it diagnosed from an FNA? It can be because those cells are so spindle-like and so transformed that we know on FNA, we can see how horrific those cells look. They do not look like they're supposed to at all. FNAs, we can diagnose a papillary thyroid cancer because a PTC has very unique nuclear features. So we have the ability, if we have a good sample, to be able to say something is indeed a papillary thyroid cancer from the FNA. Often we can do that also on an anaplastic, but that's not the case in follicular because follicular has to have that invasion outside of the thyroid capsule. But we talked about the molecular test. We use that kind of to help us diagnose, and that's especially when we have an FNA that we don't know what it is. And can we add some of these molecular tests to get a better idea of, is it a higher percentage of being cancer or a lower percentage of being cancer? But once we've been diagnosed and we have cancer, well, what do we do with this information once we have it? Some of us, many of us, will undergo complete thyroidectomy and will not need to have systemic therapy or go through chemotherapies after that. But what we can do when we have residual disease, when it's spread to lymph nodes that we can't remove, when we have spread to the lungs, we can start to look at what are those mutations that we found? What were those molecular markers? And fortunately, I know this is a really busy slide. I don't want you to pay attention to that. This is that whole pathway that I talked about. Every mutation in thyroid cancer pretty much activates this MAP kinase pathway. But what's interesting and what's really important about this is that many of these different mutations that we look for and that are on all of our molecular tests, we actually now have drugs that we can use against them. So that's how we use the molecular tests now. So we can use them for during diagnosis to try to understand try to predict whether this is truly a cancer or not at the FNA stage. But after it's developed and we know in fact that it is cancer, those with residual disease, it's so critical to know what these different mutations are so that we can start to use some of these drugs. And that's where specifically we talked about the NTRK, so NTRK, the larotrectinib, entrectinib. The unfortunate part about a lot of this is we don't know how these drugs work, right? So we know that we can target them, but we haven't figured out exactly how they work. That's what I do in the lab every day, is try to figure out how they work and try to get ahead of the curve of what's going to happen when they stop working. And how do we find what we talked about, the second, the third generation? How can we predict how that drug is going to get around these molecular tests and find a new way to keep activating this exact same pathway? And that's where molecular tests come in again, because when we find that a patient stops responding, or a patient's tumor stops responding, not the patient, they're stupid tumors, are no longer responding to these different therapies, we can try different genetic tests and these molecular tests to see if we can find a different mutation and try to go after it from a different angle. So we can continue to use those molecular tests to try to find another way that we can come at that tumor. Sorry. Okay. So my ThyroSeq test says positive, intermediate, high. What kind of action do you think this would be good to take? Is monitoring okay, or something more active? The ThyroSeq says surgical management, often thyroid lobectomy is typically recommended. So again, I'm not a clinician, so this is, I think a lot of these ideas of the molecular tests, it's really important on what you have available to you, the relationship you have with your physician, and whether you can come back for continued monitoring, right? If you're seeing a clinician that is not a thyroid cancer specialist, I was diagnosed at a community hospital. It was my PCP that found a nodule. And when they did my first surgery, he said, "Oh yeah, we're gonna keep watching you. Yeah, we'll probably do MRIs every year." He had no idea how to monitor me or what to do. And I think as patients, this is our time to, luckily we have meetings like this to learn a lot more about our disease and to be empowered. And I will say, just as a patient, not as a clinician, that my track would be very different and I would have taken a very different path had I been at a center that knew how to treat thyroid cancer versus a center that I was a one-off. And although I do many days regret having had a complete thyroidectomy, I do in heart of hearts believe that was the best option for me. And even in retrospect, because for so long I was seen in a community setting and they had no idea how to continually monitor me, that my physician was not adept at doing ultrasound and tracking it. So I think those are all parts of the puzzle that we need to put together. And each of these pieces makes that picture a little clearer. But unfortunately, there's always a piece of that puzzle that's missing and leaves an unknown. So I think, we try to make the best decisions we can, but I think a lot of it as we advance this is to make sure that we're with providers that really know the latest and the greatest and have the resources to continue to follow us. If they're doing 2-3 thyroid ultrasounds a year, that's not the person you want monitoring you to see whether that tumor is growing or not, because there's going to be so much error and variability even between every one of your scans because they're not doing it very often. So do we use the exact same test for diagnosis and advanced disease? And do we use different brands for each? So this is a great question. And yes and no. So we can use these exact same tests after surgery and to try once we have more advanced disease. Often though, a lot of times, So I will say that those are absolutely available and those can be used in advanced disease. A lot of cancer centers and larger places that are treating thyroid cancer are also using their own tests. So they're not using those commercial tests that I talked about, which is what we usually do at FNA. But once we get to a more advanced stage, and especially at the bigger centers, many of them have their own molecular panels that they'll run, and they'll have many, many more mutations than what we normally see in thyroid cancer. And that's where we find things that are different. And that's when we find the patients that are ends of 1, ends of 2. And that's actually how we continue to learn more about thyroid cancer and understand more mutations. And that's why those tests are constantly evolving. That's why the ThyroSeq that you had 10 years ago is not the ThyroSeq that you're going to have today. It's because over the last 10 years, we've acquired so much more information and have many more targets and mutations that we've identified. So we've expanded these panels. Yeah.
I want to say thank you for looking for second line and third line. My husband is BRAF positive anaplastic thyroid cancer, and the BRAF and the MEK are working wonderfully for 4 years. And so he had a testing and genomic testing 4 years ago. Do you recommend, doing another test? There were no other actionable mutations at that time. Do we try to keep up with that? Is there a timing thing?
So that's a really good question. And the unfortunate thing is thyroid cancer doesn't follow any of the rules that anything else does. And this is the thing that I think is it's so frustrating to me as a researcher as well as a patient, because it doesn't follow the rules. And so thyroid cancer is also one of these tumors that we talk about that has we say very low mutational burden. What this means is very often we can only find 1 mutation, maybe 2 mutations. We do not understand to this day why BRAF alone would ever lead to an anaplastic thyroid cancer, because in other cancers, we see BRAF needs to acquire a bunch of other mutations, things that you hear, AKT, PI3 kinase, P53. I mean, I'm just throwing out names. We don't need to go through the biochemistry and all of the biology of it. But thyroid cancers tend to be really quiet. We talk about being quiet in a mutational sense. So what I would say is no, I wouldn't recommend always going to look, because we know thyroid cancers don't tend to mutate really quickly. When it's really time to take another look is when the therapies stop working, because there may be either another mutation that has popped up that may be targetable, but there also may be a change. BRAF V600E doesn't usually change, but we do know RAS mutations, you can get a mutation in just a little different part of the gene, which means it's a little different part of the protein, which means it just changes a little bit. So instead of it having a hook this direction, it might have a hook that goes in the other direction. And with that, it means we can find different drugs that will fit into those different hooks. So that's when it really becomes important to look at doing additional testing. But because thyroid cancers don't follow the rules of other cancers, it's not the same thing to kind of keep doing those serial biopsies, because we're just not finding those new mutations like we do in a lot of other cancers. The other thing is that we often don't find a lot of very different mutations between the primary thyroid cancer and then the cancers that we find that spread. So the lung mutations will often have the exact same mutations as we saw in the primary thyroid tumor. Let me do the online and then I'll come right over. So if ThyroSeq 2 was done on benign follicular sample, is the result even of value, since they were benign cells that were tested? But clearly the second time the needle was in a different part of the nodule. So benign is benign, and it doesn't mean that there's necessarily a tumor there. So benign means that it's not cancer. Is it possible that there could be a cancer beside it? There's always the possibility of that, because we don't know what we're going into. And sometimes thyroid cancers also have multinodular, I've heard that term, or multifocal, meaning that they're in a couple different places, that there can be a couple small tumors. They're not one giant tumor necessarily within the thyroid. I have RAI resistant Hertel cell. They tested thyroid genetics 5 years ago, lung biopsy. The only thing was PDL1, 95%. They check for more things now. At what point should new samples be tested to see if there are new things to target? Hertel cell actually is a different beast in having the PDL1. We've shown, as well as quite a few other groups now, that Hertel cell actually looks like it might be amenable. It might respond to immune therapies. A lot of the thyroid cancers don't respond to immune therapies, or we can do it immune therapies in combination, especially in anaplastic. But it looks like Hertel cells might actually, because of that PDL1, it's not a mutation, it's a change, and it's an overexpression of a protein. But PDL1 basically essentially puts the brakes on your immune system. So it stops the immune system from being able to see your tumor and being able to do anything. We can use different types of drugs that essentially take that brake off. We block PDL1, take the brake off, and now all of a sudden, some of these immune therapies can work. So it's a little different way in which we go about it. It's not a true molecular test in trying to look for a mutation, but instead looking for a change in other cells and the way your immune system sees the tumor. If the report says the specimen cellularity adequacy for interpretation is limited. So if you end up with a positive test off of, even with a very small sample, then you believe it. If it's indeterminate, and it shows that there's a lot of other junk in that test, that the FNA doesn't have a lot of cellularity and that it doesn't have a lot of thyroid cells, then you weren't detecting the right thing, unfortunately. So you might have a false negative, meaning that they just didn't make the tumor. It doesn't guarantee it makes that there's still a tumor there, but there is a higher likelihood if there was less cellularity in that.
Hi, I kind of have two questions. I had a lung biopsy because I have lung mets, and this is 29 years after original diagnosis. So RIA, refractive, etc. So I had a bronchial occlusion, and they did a resection of that and sent it to Foundation One. So I have BRAF, B600E plus TERT promoter. So my two questions are, number one, does that mean that my cells are poorly differentiated? Does that necessitate being poorly differentiated? And number two, can other mutations occur later on, or will the ones that I have, can it lead to anaplastic?
So I'm going to go to my next slide as I answer this, because this is unfortunately the bad news is that none of this is a crystal ball. And all of this is about prediction. So because it has BRAF and TERT, no, it does not mean it's poorly differentiated. Could it progress? Could it be? Yes. Does it mean? No. TERT is TERT is one of those, well, and this is also debated, but TERT is one of those rare mutations that we see that actually kind of adds on to what we usually see in thyroid cancer. So the BRAF, the RAS, DICER, P10, the things that I talked about, kept mentioning, usually those are they're the only driver. They're the only ones that really we think are making thyroid cells turn into cancer. TERT and P53, and sometimes you may hear PI3 kinase, those are other mutations that we sometimes see, and those are usually associated when we see the disease starting to progress, when it's moving towards potentially more poorly differentiated or anaplastic. It does not mean that it is going to go there or that it is there. It's just those are the mutations that we sometimes see start to accumulate as the cells start to push in another direction. And I will also say what is also really unique about thyroid cancer, and I showed you MAP kinase, like, again, we don't need to go through biology, but just hearing those things, is it's also one of the few cancers that we say the mutations are mutually exclusive. That means we don't see BRAF mutations with RAS mutations. It finds a way, the thyroid cancers find a way to activate those pathways and they keep them on, but they don't get more mutations. And again, we don't understand why. It doesn't follow the rules. So it makes it really challenging for us, as we're doing the research and as we develop these strategies and as we develop these different treatments, because thyroid cancer doesn't follow the rules. And it also means, even though we have all of those inhibitors that I showed you, all of those drugs for a lot of these targets, they don't always follow the same rules with how they work in a thyroid cell as they do in some of the other cancers as well. So that's my shameless plug to all of you, that let research be done on your tissue. Let your doctor report your mutations to people, de-identified, so that we know what mutations are there, so that we can dig into the biology to understand it deeper. And I think that was a big challenge, and one of the reasons I never intended to actually research my own disease. There's a little bit of ignorance is bliss. Sometimes knowing as much as I know is terrifying, especially since I didn't have molecular tests. So I have absolutely no idea what my FTC looked like 25 years ago. And I am terrified that lung mets will come back 25, 30 years later. But what was so frustrating is I realized we didn't understand. There's no research and nobody understands. The amount of knowledge that we have gained, even since I've been in doing this research of understanding how many mutations that we see in thyroid cancer and how we've expanded all of these molecular tests, because we now know more mutations and we can test them in these panels, is just unbelievable. But the only way we're going to continue to do this is to share our data. And that doesn't mean in a bad way, but just making sure that, these mutations, that we continue to share this data so that we can continue to find out more about what's going on and hopefully get ahead of the curve and develop these next therapies. And that's the only reason we know that pediatric patients have more fusions than adults, and we don't know why. But it's just through the research that we found that out.
Maybe it's a comment instead of a question, but I hear you saying that these mutations are everywhere and happen all the time. Maybe the word isn't mutation, maybe it's variant. And the language that we use to describe it might help drive comprehension and understanding on patients.
I think that's a great point. And the one thing that I will say is, and it's challenging because, and you've hit the nail on the head of what do these words mean and how do we use them? Because they mean something different to everyone. And honestly, when Jerry initially said, talk about molecular tests, I was like, crap. Because this is not what I usually talk about at this meeting. But I also felt like it was absolutely essential to talk about the genetic testing as well. Because I think, we sometimes conflate the two of them and we don't understand the differences of looking at the changes that are occurring in the tumor versus the changes that are occurring throughout the body. And variant actually is a really good point to bring up, because for different clinicians and different people within this field, even variant means something different. And I use variant when we talk about it. When I talked about some of those mutations, like especially in RAS or in dicer, there's actually different mutations that can occur, and they all have slightly different changes that happen. And that's when I start talking about variants, because I'll just say dicer mutation, but there's 4 or 5 different variants of those mutations. And to the patient, it probably doesn't matter right now, because we don't know what those different variants and different types do. But I think biologically they're doing something different. And even though we don't know yet, hopefully in another 5 years we will, and then that will make a significant difference. But I think you've hit the nail on the head as well of we need to spend a lot more time, and I try to do it, and also try to bring patients into our research to get them involved very early on, so that we're using patient-centric language, that we're not being offensive with the things that we say. And I mean, I caught myself with saying the patient wasn't responding. It's not the patient that's not responding. It's the damn tumor that stopped responding. And being really careful about it, because words do matter. And I think we have to also be really careful about the words, and when we're communicating with our physicians and our clinicians, to make sure that we're using the words and they mean the same thing to each of us. And I think it becomes really challenging when we start talking about these molecular tests, genetic counseling, and things like that, to make sure we really know what these words mean, because it can be really terrifying to hold. You've got a germline mutation. What does that mean?
Considering when you're downstream of RAS on the MAP kinase pathway, and you've got all these potential drugs that are available for very specific parts, I would think that that might be a little bit risky to do combinations when MAP kinase is so fundamental to normal cell function as well. Do you find that novel combinations are giving novel side effects that you wouldn't get with the single kinase inhibitors?
So, okay, so I've got a biologist in the room that wants to talk biology. Okay, I tried to keep it simple, but you opened the can of worms. So, no, exactly. So MAP kinase in these pathways, this is always the challenge in cancer and any cancer treatment, is these pathways, the cancer cells have co-opted, but every single cell in your body uses these exact same pathways. And it's absolutely essential. So that's why we have side effects. You know, chemotherapies, traditional chemotherapies just went and tried to kill the cancer before it killed the patient, right? So we have been trying to explore and play around with this in the lab of trying to inhibit and trying to do this by changing the timing. So put the drug on for 10 hours and then take it off. So, and see if by doing different kinds of pulses or hitting at different levels within that pathway that we can really just screw up and confuse the cancer cell, because the cancer cells are exquisitely dependent on these pathways. Every single cell in your body is going to use them when they need them, but the cancer cells are absolutely dependent on it. And it's my thought that if we can use that as the cancer's Achilles heel and keep just hammering it in different ways, trying to stop it, the normal cells are going to find ways to get around it because they don't need it all the time. And they're going to get sleepy and they'll just say, okay, fine, I'm not going to worry about this right now. The tumor cells, they don't have that choice. Without it, they die. And that's how we're really trying to think about it now. And we do. So we try using different MAP kinase inhibitors. This is why sometimes you'll hear using the BRAF inhibitor and a MEK inhibitor simultaneously. We also, you probably noticed that it wasn't clean, those lines. They don't all go in a straight line. There's different pathways that come in from different directions and go in different directions. We can actually try to inhibit and hit those pathways as well. And again, everything to try to disrupt the cancer cell and disrupt the cancer cell more than the normal cells. So my genetic test shows RAS. Is there anything in the pipeline for that? Yes, there are different RAS specific drugs. So traditionally we thought RAS was undruggable. That's changed recently. And there's a lot of new drugs that are actually targeting RAS. And we're hoping that there's going to be clinically available drugs that'll target RAS the same way they target just the BRAF V600E mutation. And that's something we didn't talk about, or I should have mentioned, is many of these drugs, we're trying to go after just the mutation. So BRAF is one of your normal, everybody needs BRAF. It's BRAF V600E can't get turned off. And what we do, and we've developed drugs, is strictly to the V600E and trying to turn off what can't be turned off. The rest of your cells have a BRAF that can get turned on and turned off normally. It's only when it has that mutation, the V600E, that it can no longer be turned off. So we've been trying to develop, the community at large, trying to develop drugs that will target those specific locked on mutations. And that way, hopefully we eliminate some of these inhibiting these pathways in the normal cells. We can try to inhibit them only in the cancer cells. BRAF is the most common mutation in PTC, but it also that it makes PTC more dangerous. What gives? So yes, BRAF is the most common mutation. We thought it could be associated with more progressive disease, but we don't understand what those switches are. So we know it carries a risk for potentially going to poorly differentiated as well as to anaplastic, but we don't know what the difference is. We don't know what all of those switches are and why some will stay as a PTC and remain really well differentiated and respond to RAI and stay in the thyroid and can be removed with surgery versus those that just go wrong. I know it's frustrating and sound like a broken record. I wish I had better answers. Thyroid cancer doesn't follow the damn rules, and we just need to figure out why. Are Mets from FTC usually FDG avid or only if dedifferentiated? So FDG is, Mets are usually FTG positive. The reason we use FTG is actually using sugar, and it's just a way that we image, but most cancers, once they've metastasized, and particularly if they have gone to a poorly differentiated, will pick up FDG, and that's why we see it in a PET scan. And that's why we use that, because they don't pick up the radioactive iodine as effectively anymore, but we can still find them with the FDG. Yeah. Or you can yell and I can repeat it.
Is there such a thing as like a bad genetic test, like that they would pick up one mutation but could have missed others? That's one part of the question. And then the second is, are there studies that we can sign up for? Like I have a BRAF mutation and am open to be followed for however long if it means that something could be solved, but my doctors aren't involved in any of that. So just curious.
So yes and yes. So I wouldn't say bad genetic tests. I would say sometimes the panels, like what we talked about, the panels don't encompass everything. So it is possible that you'll have something that's not in a panel. So testing that's often done in centers, like right now, I mean, I know for us at CHOP, we test, or we used to test almost every single pediatric thyroid cancer patient that would come in, and we use an in-house. So it has many, many more mutations than what is detected on some of these commercial panels. So we can see a lot more, and that's how we found all of these fusions, because like I said, not all of the fusions are on some of these commercial panels. So I think it's not necessarily that it's bad tests. It's just, what is it testing for? And sometimes they're too narrow. And because we don't know everything about thyroid cancer, it's difficult to know whether our tests are broad enough or not. And also, as I alluded to, populations are different. We don't know enough about whether ancestry and things like that changes the prevalence of what mutations we might have. And we already know that the mutations look different in pediatrics than they do in adults. For research, so contact me. We have a child and adolescent thyroid consortium. It's primarily for kids and young adults at this point. But getting involved in the Count Me In and many of these, more global that are pan cancer, not thyroid specific, at least the information is in those databases and it at least is available. But this is one of the things that, we have been thinking about as a community, is how do we get more to be able to have our thyroid centric databases and have that information.
Okay, back to the right question. I was diagnosed at 54 and have RET, TERT, and 6 or 7 other mutations. Does having that thyroidectomy, if my cancer was progressing towards anaplastic, does having a thyroidectomy slow or halt that process, or is that another crystal ball question?
It's a little bit of both. The thyroidectomy, especially if the cancer is mostly contained in the thyroid, it's going to stop it. We're going to get a lot of it out. So if it's out, then it's out. The thyroidectomy is going to probably help inhibit a little bit of that growth, because we do think that the primary tumors are probably sending signals to cells around the body. So I put this up just because tumors are complicated, right? And we already talked about it, that thyroid tumors aren't just thyroid cells, but they have a lot of other cells. And if we go in for an FNA, sometimes we get those other cells. It becomes a very complicated ecosystem. And I think the way to think about thyroid cancer is it's your entire organ has gone wrong, right? It has completely corrupted that organ and made it not do what it's supposed to and not follow the rules. And it has the potential to move around and go to other places. And once the cat's out of the bag, it's out. So the only good part of that is thyroid cancer doesn't follow the rules. So just because it gets out doesn't mean that it's a death sentence the way it is in many other cancers. That's, I think, the only positive, and it's not universal, and I'm not trying to make it as a blanket statement, but many of the metastases that we see in thyroid cancer don't act the same way and as aggressively and grow as quickly as we see in other tumors that metastasize. That absolutely is not a good thing to say to someone who has progressive disease, and I understand that. So it's one of those things that we're still looking at.
My mom has anaplastic thyroid cancer, and her mom passed away back in 2015 from it. And our home doctors in Kansas City said that they told my mom, there's no way you have anaplastic because it's not genetic. And then she went to MD Anderson and they said there's not enough research to know if it is or not. Either way, my sister and I both got our thyroids completely removed, and they found cancer cells in mine. So I'm curious if there's any research that shows that there might be.
So that's where I don't know. There isn't research that I know of that's talking about anaplastic being a genetic. But I think this goes back to the beginning, is there's a lot of things, and especially when I talk about those SNPs, those SNPs, like there's a lot of parts of our DNA and of our blueprints that we don't understand. And we did the whole human genome project and we sequenced everything and we thought this was going to tell us everything. And it was really kind of an oh shit moment that we realized we don't know half of what is in there, probably actually don't know 90% of what's in there. And there's a lot more than just the code and the blueprint, it's how it's folded as well. And so with that, there's so much that we don't understand. And I think what we need are a lot of these bigger studies that will look at the entire genome, because what we looked at a lot of times was looking for these specific mutations, and most of the time only in the tumor. But we didn't look at the germline and find out whether there were other things that were there that increase the risk that may predispose. It's not the same thing as having like MEN2B or MEN2A and having a predisposition for medullary. We have not found kind of that silver bullet that is definitely associated. But I think there's a lot of things that we still need to discover and understand, because as we spend more time investigating and looking at thyroid cancer, we see a lot more familial trails of thyroid cancer. I didn't know in anaplastic, but we definitely see this now more often in follicular and in papillary. And traditionally, in 5-10 years ago, we would have said it's not associated with being a genetic mutation or in familial inheritance. I think now we're thinking much differently, but it's not an obvious mutation that we can say, oh, yep, you got BRCA, now you're at risk. We haven't figured out what those signals are yet. They're a lot more subtle, what those markers and what those signals look like, that probably are going to be associated, I think, with being in families. When they say rare, small, uniform nuclei on cytopathology, is the meaning only few found? No, not usually. Actually, when they say rare, small, uniform nuclei, means that usually I think that means that it's rare that they find the small uniform nuclei. This is where it's really hard. And words don't always mean the same thing to every cytologist and pathologist. So it's difficult at times to kind of go through and make blanket. All right. Thanks, everyone.